Okay, well, thank you very much for this invitation, and we're about to lower the tone, the scientific tone of this meeting, because you're going to hear me talk about surgery. But I'm hoping that by the end of this talk, you'll have a better grasp of the issues surrounding adrenal surgery and how we make decisions about how to approach it. So I have no conflicts of interest, and I'm not going to talk to you about what the indications for adrenalectomy are, because I think you all know this very well. I'm going to focus essentially on this issue here. In other words, when you've got the algorithm to the point where surgery has been decided on at the multidisciplinary team meeting, and I should underline that this sort of surgery should always be fed through an open forum, because that's how you get the best results and the best decisions in this field. So the patient needs an adrenalectomy, and the surgeon has to then offer his or her view on what the best approach is in this specific patient. And we have three options. But to understand this, you really need to take a long run up to understand how adrenal surgery started. And in particular, we need to understand what the challenges are in adrenal surgery. And the problem is this, that when the human body was being designed, they didn't have the adrenal surgeon in mind, because the adrenal glands are in a very awkward place. If you approach the adrenal glands from the front, there is a great distance between the anterior abdominal wall and the retroperitoneum, where the adrenal glands live, and they live high and posterior. So the obvious thought is, well, why don't we approach this from the back? But if you approach it from the back, the adrenal glands are behind the ribs. So anatomically, they're a difficult place to go. And then when you get to the adrenal gland, because they're endocrine organs, and therefore ductless organs, they rely fundamentally on a very good blood supply and blood drainage in order to allow the circulation of their hormones. And therefore, you have an arterial supply which comes from above, from the diaphragm on both sides, directly from the aorta on both sides, and from the renal artery. These arteries tend to be quite small, but problematic if they're not controlled. The venous drainage is different on each side. On the right, the adrenal gland is drained usually by a single short adrenal vein which comes off the back of the inferior vena cava. That's the largest vein in the human body. On the left, the drainage is more irregular, but tends to be centered on two veins, namely the vein that drains into the renal vein, and another vein, sometimes called the accessory adrenal vein, which is in fact the inferior phrenic vein. All of these veins and arteries have to be controlled during a successful adrenalectomy. So the history of adrenal surgery, like many surgical stories, didn't start particularly well. So the first adrenalectomy was performed in 1889 by Knowsley Thornton. Now, he was born in Northampton, but spent his whole medical career in Edinburgh. In fact, he was Lord Lister's houseman. He performed the first operation, and the patient had all the predictable, if you like, today, predictable complications of the surgery if the surgery hasn't got a very well-defined technique. So the patient spent 3 months in hospital with bleeding. They had a nephrectomy during surgery and infection. Now, Charles Mayo performed the first adrenalectomy for pheochromocytoma in the United States, and those were the days when you got on the front cover of Time magazine for doing an operation. Now you end up on the front page of a newspaper only if you do something terrible as a surgeon. Now, the interesting thing about surgical publications is that surgeons, probably like all physicians, only publish good results. So you can imagine that Ratman Walters in 1934 thought that he was publishing very, very good results when he did 10 adrenalectomies for Cushing syndrome, and the mortality was 30%. So you can imagine what the unpublished data was like from elsewhere. But the person who, if you like, who left his mark on adrenal surgery for the longest period of time was Hugh Young, when he described the posterior open, of course, approach to the adrenal gland by the removal of the 12th rib. So he got round the problem of the adrenal glands being very posterior, very high, by just removing the obstacles. And this technique remained very popular for a very long time. In fact, you could say that it was still being used into the 1980s, certainly. But open adrenal surgery, and I remember open adrenal surgery because I was trained at the end, if you like, of open adrenal surgery, and it was an unpleasant operation because you couldn't really see what was going on. If you did it through the back, it was done by feel often, even once the rib had been removed. And if you did it that was from the back. If you did it from the front, you also had difficulties in exposure, especially in Cushing's patients who tend to be overweight, and also had a poor there was poor hemostasis because there's a capillary ooze in these patients. And of course, in pheochromocytomas, there's the additional problem of blood pressure control during the operation. And there was no real consensus to how best to do this operation, whether from the front or from the back. So if you look at these images here, there are a whole variety of options: midline laparotomy, a rooftop incision, or unilateral subcostal incision. Or the alternative was this, and this is the posterior open approach. And in this context, there was a debate about what the best approach was. And in the 1980s, a very illustrious group of endocrine surgeons, including Colin Russell from Belfast, who examined me for my Part 3F RCS, it shows my age now, and Bertil Hamburger from the Karolinska in Sweden, and the inspirational John Van Heerden from the Mayo Clinic in the US, published a paper looking at all the available information and adding their own expertise, and they concluded that the posterior approach was the way to go because the patient had less ileus, less respiratory complications, and tended to go home a little bit earlier. But everything changed in the 1990s because we replaced big incisions with long instruments. And it all came down essentially to the fiber optic scope. So the laparoscope allowed us to look into the abdomen, aided by insufflation, initially with air, but then with carbon dioxide, because it's safer. And that stimulated the development of instruments that could be used within the abdomen so that an operation could be performed. And Michel Gagné, who's a French-Canadian surgeon, performed the first two laparoscopic adrenalectomies on a Cushing's patient and a pheochromocytoma. These operations lasted a very long time by today's standards, because of course these are pioneering operations at the time, and they didn't really have a clear idea about how to achieve the access to the gland, and they didn't have all the technological hemostatic advances that we have now available to us. And I'm just going to show you, because I don't have much time to give this talk, but I just want to show you what this involves. This is a pheochromocytoma patient on the right. So this is a right laparoscopic adrenalectomy. This is the right lobe of the liver, a slightly fatty liver, you'll see. This is the tumor. And this is what we do. We essentially mobilize the right lobe of the liver. This process takes 20 or so minutes to get full mobilization of the right lobe of the liver. And once we've completely mobilized the liver, we lateralize the pheochromocytoma, we have access to this, which is a short right adrenal vein. And just to the right of that clipping device is the inferior vena cava. And it's absolutely essential that this vein is controlled, because if it's not controlled, the bleeding can be quite significant. Once the adrenal vein has been controlled, it's sufficient to control the small adrenal arteries and then remove the tumor. So at this point, we had a new technique, which is the laparoscopic adrenalectomy, against what was considered at that time as the best alternative traditional approach, which is the open posterior approach. And it's interesting that the influence of senior surgeons at the time, who all used the posterior approach, and therefore there was some reluctance to take on laparoscopic adrenalectomy because they thought it might not be safe. But it became quite clear pretty quickly that patients got better quicker. And if we use length of hospital stay as a surrogate measure of how effective an operation is, there's a big difference. No randomized controlled trial can ever be performed in these patients, but what we do have is the benefit of having patients who need bilateral adrenalectomy. So this is a young lady with von Hippel-Lindau syndrome and metachronous pheochromocytomas. The right adrenalectomy was performed by my very experienced predecessor, John Lynn, and you can see this large abdominal incision. The patient spent 9 days in hospital, but the patient then, a few years later, when I came to Hammersmith Hospital, had required a left adrenalectomy for a pheochromocytoma. The length of operation was almost identical, but the length of stay was much shorter. And these are the port sites at 2 weeks after surgery. And you could say that it's self-evident that a laparoscopic approach is better as long as you can prove that it's safe. This picture is one that I cherish because this is a young lady who, right at the early part of my consultancy at the Hammersmith, had a bilateral laparoscopic adrenalectomy. And this is for Cushing's disease. And this is day one after a bilateral adrenalectomy. It's incredible because I remember as a training surgeon, as a registrar, how these patients spent 10 days in hospital and had a lot of pain. And just look at this smiling patient. And when we looked at the data that's available to us, we could see that the open anterior adrenalectomy patients spent a long time in hospital, and the posterior approach was associated with earlier discharge because they had less respiratory problems and ileus. But the laparoscopic approach at that time was associated with a 2-day hospital stay, clearly therefore advantageous. So as a consequence, the laparoscopic adrenalectomy in the 1990s and the beginning of the 21st century became the standard of care, certainly for small and benign adrenal tumors. But as it always occurs, with time our expertise improves. So larger tumors were operated on, and we also started to perform surgery for solitary adrenal metastases. But there are some people who are simply pioneering, and this is Professor Martin Volz, one of the most generous surgeons that I think that I've ever met, because this is a man who combined the posterior open approach with the new technology. And he said, well, why don't we combine the posterior approach, which is favored by the traditional surgeons, with the laparoscope? And of course, there seem to be so many problems in doing this, but he had a learning curve of over 200 patients and has then gone on to essentially teach everybody else how to do it, including myself, and there are many other surgeons like me that are very grateful for this. So what is this rate peritoneoscopic adrenalectomy, and how is it so different from a laparoscopic approach? Well, the first thing to say is the patient position. The patients are not in the lateral position like a laparoscopic adrenalectomy, but they are prone. And these are two patients. The left patient is the ideal slim patient, and the right-sided image is the real world. And the patients are in this position. It's very important to eliminate the lumbar lordosis in these patients to allow access to the retroperitoneum. And this is what the patient looks like draped. And I'm going to show you just a part of a very short video showing you what you see when you start this operation. And this is where the problem is, that most surgeons are very unfamiliar with this field because there are very few landmarks. But I will explain to you that what you're seeing here is, with the benefit of 20 millimeters of mercury of pressure, the retroperitoneum, the perinephric fat. Here is the spine. Superiorly, we'll see the diaphragm, and in this fat at the bottom, underneath that is the right kidney. Now, it's worth saying that this video is in real time, so there have been no edits. And what you will see is that after not many minutes at all, we have alighted on the adrenal gland, which will come into view just in a few moments' time. Now, this is, of course, incredible because, as I said, if you did a right adrenalectomy, it takes you 20-25 minutes to get the right kidney, the right lobe of the liver mobilized. And this here is the right adrenal gland, in a patient with Conn syndrome. It is true that not all operations are like this, and it's also true that this is a slim patient. The aesthetics of the retroperitoneoscopic approach are also very attractive because the patient cannot even see the port site, and therefore the aesthetics, as far as they're concerned, is excellent. Now, we started doing this, adopting this technique in about 2009 or 2010, and we compared the results of the laparoscopic approach and retroperitoneoscopic approach, and then went on to do two meta-analyses, the most recent of which was published in 2020. And essentially, the conclusions are the same, and others have gone on, if you like to, I won't say copy, but reproduce the same results. And what these results show is that the retroperitoneoscopic approach takes less time for the reasons which are evident from the video I've just shown you. And because the operation is done in the retroperitoneum without reaching the peritoneal cavity, because you must remember that the peritoneum is very well innervated, the patient has less pain. If they have less pain, they require less opiate analgesia, if any at all, and therefore they start eating and drinking sooner, mobilizing sooner. The other difference between the retro and laparoscopic approach is there's one complication which is unique to the retroperitoneoscopic approach, which is intercostal nerve neuralgia, which happens in about 1 in 20 patients and can be quite severe. But the question here is, yes, the length of stay is shorter. Yes, the analgesic requirement is lower, but what is the clinical significance of this? So if we compare the two approaches, how do they differ? Well, a laparoscopic approach is favored by most surgeons, most general surgeons, because it's a familiar approach and a familiar environment. It's easier to teach. But the price you pay is you have to mobilize a lot of organs to get to the retroperitoneum. The retroperitoneoscopic approach, on the other hand, is unfamiliar and possibly technically more demanding, but it allows a direct access to the adrenal without any adhesions. Furthermore, if you have to do a bilateral adrenalectomy, then you don't need to reposition the patient, which is also a great advantage. So, in essence, our view is that these two techniques are actually complementary. So we believe that the adrenal surgeon should really be familiar with both of these techniques so they can select the technique which is most suited for the specific patient. So how do we then choose what approach to use? Well, we consider the size, the position, and the relations of the tumor. And then there's some patient-specific issues. So here we have an example of a very large right-sided adrenal tumor. There is no minimally invasive approach in such a patient. And by the way, these are not the same tumors. This is just another example of a tumor which is simply too large or too firm to remove laparoscopically or retroperitoneoscopically. Here we have examples where there's the suitability for the different techniques depending on the position. So if the tumor is anterior or very high, it lends itself to a laparoscopic approach. Whereas if it's posterior, like here, this lends itself to a retroperitoneoscopic approach. And this tumor here, which is more anterior and inferior, is probably best done laparoscopically, whereas this one could be done using either technique. Sometimes we look at the relations of the tumor. So here's the tail of the pancreas, and the plane with the tumor is not very clear. So in such a case, it's probably better to approach it laparoscopically. And equally here, we'd be a little bit worried about the relationship of this large tumor with the vessels, the renal vessels. So again, in that case, most surgeons would say that the laparoscopic approach lends itself to this specific patient. In other cases, we would consider the malignancy risk in the patient. So if we feel that there is a high malignancy risk of the patient and the relations, for example, with the kidney are not clear, then we will choose the surgical technique which is most suited to this problem. And this is another one which we perform laparoscopically. So our default is probably retroperitoneoscopic, and we look for reasons why that's not a good idea. What about the patient factors? Well, if you've had a large subcostal incision like this and a liver resection, then it's best to go through the back. And the other issue is very personal to the patient. This patient didn't mind having a retroperitoneoscopic approach, even if the ports were going to disrupt this body art. So in conclusion, adrenal surgery is minimally invasive now for all but the largest adrenal tumours or cancers. And the retroperitoneoscopic adrenalectomy has some advantages over the laparoscopic approach, but it's important that the approach is tailored to the specific patient and the specific pathology to achieve the best result and the safest result. And I think that I cannot underline enough what I said at the beginning of this talk, and that is that the discussion of these patients in open forum with the appropriate constituents of an MDT, which includes an endocrinologist, pathologist, radiologist, is essential to get the best outcomes in these patients. I'd like to thank you all for listening, and I apologise it's such a short talk on what is quite a big subject. Thank you very much.
Thank you very much, Professor Palazzo. I think it's quite informative for physicians to be familiar with the various techniques. We have got over 600 participants in the audience and a few questions. So what are your thoughts about the novel upcoming ablation therapies?
I think that if we can accumulate evidence that demonstrates that the outcomes are the same as surgery, then there will be a future for ablation, radiofrequency ablation in particular, in CONS patients. But the diagnostic surgery and surgery for malignancy will continue.
Thank you. The next question is about robotic surgery for adrenals. Any plans?
Yeah, so the use of robotics has definitely been tried in laparoscopic adrenalectomy. In retroperitoneoscopic adrenalectomy, there doesn't appear to be any benefit. However, in the laparoscopic approach, the robot may be of assistance, it would appear, in patients which are right at the technical limit of a laparoscopic approach. So there is some evidence that if you have a large adrenal tumour, which perhaps laparoscopically might not be removed laparoscopically, but the use of the robot, because it provides three-dimensional imaging and improved dexterity, may, but only may, be an advantage. It should be underlined that the more experienced the surgeon, the less value the robot has in adrenal surgery.
Thank you. And do you require two surgeons? Do you need to have two surgeons present for adrenal surgery?
Somebody has to hold the camera. So if that's a surgeon, then yes.
And the RA approach, would it be better for Theo, as there will be less manipulation of the tumour during surgery?
I think that the answer to that is there's no evidence that it's superior in terms of blood pressure fluctuations intraoperatively. The manipulation of the tumour is possibly slightly lower in the rate-dependent endoscopic approach.
Thank you. And the risk of hypertensive crises after ablative therapies?
I don't think I'm able to comment on that. I don't see why there would be hypertension during the ablation of a Cons tumour.
Thank you. And in terms of training, Fausto, so we know that the volume plays an important role. Is there enough training opportunities for the next generation of surgeons? Will they have enough opportunity to learn both techniques, or is it better, given the numbers that you get, to focus on one approach, or is there enough to train on both strategies?
I think that is a very good question. I think it's universally accepted that there is a clear volume outcome correlation in adrenal surgery and in endocrine surgery in general. Adrenal surgery is not common, so in our department we'll be performing 50 or 60 adrenalectomies a year. The average surgeon, if you go into a United States hospital, a random hospital, or a random UK hospital, and have an adrenalectomy, the chances are that the operation is performed by somebody who does one per year. So this is obviously unacceptable. And the way that this is being addressed is by the centralization of adrenal surgical services, in particular the use of multidisciplinary team meetings. So in the UK today, no patient should have an adrenalectomy without prior discussion of their case at the MDT. And this has resulted in a centralization of the surgical practice. And nobody should perform less than 6 adrenalectomies a year. And these guidelines apply to the UK and US.
Thank you very much. Really grateful for your time and really interesting overview of the two different approaches.